One of the most talked about psychedelics recently is ibogaine, which has demonstrated significant reductions in symptoms of opioid addiction and treatment-resistant PTSD in early phase studies. At the same time, though, there are legitimate concerns that remain, primarily surrounding the safety profile and risk of cardiotoxicity. The conversation around ibogaine has only intensified since April of this year, when the U.S. government issued a major executive order directing federal agencies to fast-track psychedelic research and development, with a particular interest in ibogaine compounds for veterans and other groups facing other serious mental health issues. But today we're setting the hype aside to focus on the scientific evidence and find out what the clinical data really shows about ibogaine's therapeutic potential. Welcome to the integration session, where we explore the science, stories, and future of psychedelic science. Our guest today is Dr. Kirsten Cherian, a neuropsychologist and clinical assistant professor at the Stanford School of Medicine, who has played a key role in the MISTIC study, which was published in Nature Medicine in 2024 and examined a single dose of magnesium-ibogaine in special operations veterans and with traumatic brain injury and PTSD. Today, we'll be exploring how the addition of magnesium may help ibogaine's safety profile, what the evidence shows about clinical outcomes, and how the powerful subjective effects of ibogaine might lead to lasting healing. Let's get into it. Hello, Dr. Cherian. Thank you so much for joining me for this discussion. Really great to have you here.
Happy to be here.
Yeah. So your research focuses on kind of a hot topic in psychedelic science and medicine at the moment, which is ibogaine. So I want to know what kind of drew you to studying ibogaine and specifically for the population that you're interested in.
Yeah, that's an interesting question. I was actually doing a postdoctoral fellowship with Nolan Williams, and his specialty was looking at novel treatments for places where there aren't really solid treatments in place. And so he asked if I would be interested in leading the study for him on ibogaine. But he knew about my interest in cognitive function. I'm a neuropsychologist by training, and this would be working with a population of individuals with traumatic brain injuries, so special forces veterans, and then any sequelae from TBI and combat. So that's how I got introduced to ibogaine, and I led the study.
Mm-hmm. Yeah, and did you know of it more broadly, or was that sort of the first time that you heard the term ibogaine?
I first heard of it from him.
Yeah.
And so that was the beginning of a really eye-opening education for me. Yeah.
Yeah. And maybe for our listeners who are a bit less familiar with ibogaine, do you mind just describing what makes it unique among the psychedelics? And it's often called I think, an oneirogen because it produces this like dreamlike state. So I would love if you could break that down for our listeners.
Sure. Yeah. So there are different types of psychedelics. And like some other psychedelics, ibogaine is plant-based. It's extracted from the root bark of a plant that's based kind of indigenous to the west coast of Central Africa. And there it's used as a religious sacrament, like rites of passage healing ceremonies for people in the Buddhist faith. So it's been used for centuries, similar to other psychedelics. But what's interesting about ibogaine is that it acts across multiple neurotransmitter systems. A lot of the classic psychedelics that we think of, like psilocybin, LSD, those kinds of things, tend to focus mainly on the serotonergic system. And so when we look at psychedelics that work across multiple neurotransmitter systems, and like neurotransmitter systems are like kind of signal messengers that carry information within our central nervous system and our bodies. And the serotonin system is primarily thought of as being important for mood regulation, sleep, appetite, those kinds of things. But there are also several other neurotransmitters that are involved in kind of sustaining us day to day, other ones that are involved in reward-based systems, like dopamine. That one's kind of heard of a lot. The opioid system is understood to be implicated in pain management. So there are a lot of different neurotransmitters that are affected by ibogaine. And so what happens is we can see the effect of ibogaine as being something that appears to be maybe a little bit more transdiagnostic. It can affect different diagnoses all at the same time versus maybe focusing on one type of substance. Another difference would be probably the length of time of the acute effects. Is quite a long-acting psychedelic experience. So maybe around 12 hours, 14, 15 hours sometimes for the acute effects. And then it still has a residual effects phase where there's still a lot of introspection happening. The aneurogenic piece that you were speaking about, instead of having kind of maybe visualizations like colors and things like what we hear about with psilocybin, for example, with ibogaine there tends to be a very personalized, introspective kind of journey. And the aneurogenic aspect means you enter into a kind of dreamlike state, but you are awake. And that's kind of a different level of consciousness almost that we enter. And so it kind of sets ibogaine apart in that respect. Oftentimes that the visualizations that you have during this waking dreamlike state can be very self-referential, might be images of experiences that you've had in the past, might be like a slideshow of different time periods of your life, things like that. Very self-referential. There are also kind of interesting aspects of ibogaine. One of the unique aspects is that it does seem to be very effective at addressing addictions, particularly opioid addictions. And it really helps to either reduce or eliminate the very challenging symptoms of withdrawal and cravings that people experience when trying to come out of an opioid addiction. So it does actually help people to make some changes and not deal with those really challenging symptoms of opioid addiction. There are some other, differences as well, but I don't know if you want to.
Yeah. Anything
talk about
else
those.
that you think would be key for people to distinguish ibogaine?
Yeah, I mean, one thing with ibogaine is that there do seem to be some safety issues associated with it that make it stand apart from other substances, and that is something like there can be cardiotoxicity, and what that means is it can have some really negative effects for the heart, especially in people who are predisposed. So it can cause an arrhythmia that can sometimes be fatal. So people need to really be carefully pre-screened before doing ibogaine to make sure that their safety risks are really limited. Similar to other psychedelic substances, there's recommended to stay away from psychedelic substances if you have any history of psychosis. There are also some dangerous drug-drug interactions that can happen that can lead to increased chances of this fatal arrhythmia. So we need to be very, very careful about either titrating off certain medications before doing ibogaine or just making sure you are very well supervised. Usually people are wearing heart monitors throughout the treatment. They need to be really medically supervised in a way that we don't really see with other psychedelic substances.
Yeah, that's so interesting. And I've definitely heard that affiliated with ibogaine is this risk of cardiotoxicity. And I want to move into sort of the MISTIC study, which you played a large role in, and the rationale behind combining magnesium with ibogaine. Did that have something to do with the safety profile of that combination?
Yeah, and actually Interestingly, there is a guideline for ibogaine that was developed by practitioners back in 2015. The last update I saw was 2016, where they do recommend prophylactically co-administering ibogaine with magnesium sulfate intravenously. And magnesium sulfate is actually what is used to treat this fatal arrhythmia if it happens in other people. Like it's not necessarily always fatal. So if you can treat this arrhythmia with magnesium sulfate, that tends to be the protective factor. So the thought is to prophylactically use magnesium sulfate to add in a layer of cardiac protection.
Mm-hmm. Yeah, that makes sense. And leading into the study, so was that the first time that this has been done? Is the actual combination in this type of a study? What made this trial design unique, basically?
So magnesium and ibogaine are like in the clinics where people can go to get ibogaine treatment. I don't know if it's ever not co-administered with magnesium for that cardioprotective factor. Like I said, there were guidelines that were created maybe about 10 years ago where this magnesium sulfate co-administration was recommended. So that was already being done. And so individuals would, in our study, would go to Mexico to receive the treatment because you cannot receive it legally in the United States. And there they were being treated prophylactically with magnesium sulfate, kind of before, I believe during, and then for a period of time after the initial phase of ibogaine administration.
And what was the population specifically? Who were these individuals that were included in the study?
So there's a population of Special Forces veterans here in the United States that have been going down to Mexico for ibogaine treatment. A lot of it is word of mouth. They come back from war. They have been in training, in war, on missions, exposed to all kinds of blasts, from IEDs, from weapons they use, from breaching explosions. But they're exposed to so many blasts through training and through the work that they do that it can contribute to traumatic brain injury developing and not having time to heal between each blast that can cause a traumatic brain injury. So a lot of them were experiencing, when leaving the military, were experiencing difficulties not only related to combat traumas, so post-traumatic stress disorder, but also experiences of depression, anxiety, substance abuse, as a form of self-medication, having trouble getting along with people in day-to-day life, having trouble kind of managing day-to-day things like being able to control their emotions, being able to problem solve efficiently. They were having their sleep impacted. There were actually hormonal changes. It's kind of like full system changes that are contributing to problems. But these problems affect their entire life. So it affects their relationships with their family and social supports, leads to isolation. It can affect their ability to sustain work reliably, and to make that adjustment out of the military back into civilian life. So a lot of folk were finding they were really struggling after leaving the military. There's also a very high suicide rate in this population. In the veteran population, the suicide rate is much higher than in the general population. I think it's something like 20% of suicides are within the veteran population, despite the veteran population making up 6% of society. So it's a much higher rate. And it's thought to be higher still in Special Forces veterans. So people were hearing kind of word of mouth that this ibogaine psychedelic was actually making a difference for people. And so they were crossing the border, going down for treatment, coming back and reporting that they were all better. So there's a veterans organization in the United States called Veterans Exploring Treatment Solutions. led by Amber and Marcus Capone. Marcus Capone is a former Navy SEAL, and Amber was really instrumental in encouraging Marcus to go, and he went, and they started this organization thinking we need to make this available to more people. So they were a nonprofit that raises funds for individuals from special forces to go down to Mexico for this treatment, trying to reduce the number of veteran suicides.
Yeah. And what did the results of that study show? Was it effective for them? Did it help them?
Yes, it was actually really quite striking. There are really dramatic effects of this treatment. It's, with the caveat that it was an open label treatment. That means that everybody knew what they were getting, right? Like they know what the treatment is. They're not blinded to it. There's not a question, are they getting some kind of placebo? They go down with the hope and expectation that this is going to help in some way. And so we saw people, they came to Stanford before they went down to Mexico for treatment, where we did a bunch of evaluations. So I would see everybody and would do clinical evaluations to assess the level of symptoms associated with post-traumatic stress disorder, depression, anxiety, use of substances. I would assess everybody in terms of traumatic brain injury. I did cognitive evaluations, and a colleague, Randy Brown, was also involved in the cognitive evaluations, and she put in a mystical experiences questionnaire as well to try to understand what was happening. So we assessed everybody before they went down to Mexico. Then they went down for the week, came back the following weekend, and we redid these evaluations. And actually the evaluations, I forgot to mention, included brain imaging, so MRIs, and EEGs to get some electrophysiology. So they came back a week later, redid all these measures, including the imaging and the EEG, then returned home, came back 1 month later, redid everything, and then they ended up going back down to Mexico. And often ibogaine is co-administered a few days later with another substance called 5-MeO-DMT. And many of them did 5-MeO-DMT after that 1 month time point.
Okay. And so you were measuring their PTSD symptoms. What else were you measuring in terms of mental well-being?
We looked at their self-reports of day-to-day functioning, but we also looked at depression, anxiety, and cognitive function. So that's assessed through neuropsychological evaluations, looking at different thinking skills, like being able to solve problems, how effectively and quickly are they processing information, how's their memory functioning. We looked at measures of attention as well. So we did a lot of these different measures, and we found that after this ibogaine treatment, they returned and the symptoms were greatly reduced, really dramatically reduced. It was quite astounding actually being in the room with them before they went to treatment and then seeing them when they came back afterwards. To see the difference. And I didn't know what I was expecting to see, but it became pretty common to see someone very tightly wound and almost in that, fight state that can often result from PTSD, to just returning very calm, relaxed, very clear-minded, centered. So it was quite a different feeling in the room. So response rates to treatment were over 90%, and remission rates were over 80%. So remission rates is meaning that people no longer met diagnostic criteria for different disorders. So remission rates for PTSD, depression, anxiety were over 80%.
Wow.
Post-treatment.
And how does that, just for our listeners who maybe aren't familiar with traditional treatments, how does that compare to like the conventional way that these things would be treated?
Yeah, that's a great question. So conventional treatments for PTSD, which many of our participants had tried, involve psychotherapy, medications, and I think we've seen different rates, but probably between 40 and 60% effectiveness. But one of the really striking things to know about conventional treatments like prolonged exposure therapy, cognitive processing therapy, those kinds of things. Those therapies are done maybe over a dozen sessions or so, 1 hour long sessions, spaced about a week apart, and people keep coming back to do the treatment. And those treatments are pretty effective, but there's a really, really high dropout rate because doing the treatment itself is quite difficult and challenging, having to revisit the traumatic events and having to really dig into the processing of it can be really triggering for a lot of people. So a lot of people have a really tough time tolerating those treatments. So of the people who are able to stick to the treatment, there are some pretty good outcomes, but what we're seeing is a lot of people can't tolerate the treatment. So you have high dropout rates of over 50%.
Yeah, that's a huge challenge. And in terms of the ibogaine treatment, you mentioned these really exciting findings in the open label study. And how long did those last? How long did you measure those beneficial effects? Were you able to collect any long-term follow-up data?
Yeah, we did. We did follow-ups roughly every 3 months. And what was interesting, it was a little bit harder to follow up with folk. And I think they were getting back to life and getting back into kind of readjusting to the new reality, which was, not having the symptoms that they had left home with, but returning home and returning to work with a much different outlook and a different demeanor. And so it was kind of harder to follow up with people initially, but we did manage to follow through with quite a few people. And at the 1 year mark, we actually followed up with 25 out of the 30 people. So this showed that the results were sustained quite dramatically again, which is pretty impressive. The issue with long-term follow-up, though, is, again, many of our participants returned to do 5-MeO-DMT after the 1 month mark, and some other people undertook other therapies or maybe another psychedelic journey, maybe did some microdosing of psilocybin. So a lot of individuals ended up trying another psychedelic medicine in that time frame. So it's hard to say what causes what, but we are seeing the signal of sustained effects.
Yeah,
And,
that's very exciting.
yeah, an interesting point is that many of the folk who came off of psychotropic medications prior to ibogaine treatment did not end up going back on them. Some did, but many of them did not, which is interesting too.
Yeah. And I want to dig more into the subjective side because there's another paper, first authored by your colleague, Dr. Randy Brown, that takes a deeper look at this. You mentioned that she added some qualitative components. So can you walk me through those findings and what kind of elements of the experience really stood out as therapeutic or helping to process trauma, and how the veterans described their healing process with ibogaine?
Yeah, so Dr. Brown had added this measure to assess mystical experiences. And there is actually a measure out there that was, I think, originally designed for the psychedelic psilocybin, but is being used in a lot of studies right now to evaluate a certain, and be able to quantify mystical experiences that people have and try to understand what kind of contribution that experience makes to the outcomes in the other measures that we're doing, like symptom reduction for post-traumatic stress disorder, depression, anxiety, and so on. And so in Dr. Brown's paper that she was first author of, the big take-home message was that the greater the intensity of the mystical experience was found to be related to greater reductions in post-traumatic stress symptoms. So it does seem that there is this effect of having some kind of mystical experience as being contributory to reductions in psychiatric symptoms.
Mm-hmm.
And there was also another individual who did a paper, and Dr. Brown was involved in this paper as well. It's first authored by Clayton Olash. He's currently a resident at Medical University of South Carolina. And he added in 3 narrative questions to ask qualitatively about the mystical experiences, or about the experiences that people had and their perceptions. And together with the mystical experiences paper from Dr. Brown, the qualitative paper identified themes associated with the narrative descriptions that people provided of their individual, we call them journeys.
Mm-hmm. And what did those sort of show? You mentioned earlier that ibogaine can have this dreamlike state, and you re-experience things, or you have, you can look back on your life. So was that sort of similar to what you found in that population?
Yes. So they found some themes that kind of rose out of the descriptions of what happened during the individual journeys. And there seems to be this effect of almost a reevaluation of past traumas, but almost as an observer, being able to re-enter into these situations and revisit them from a different perspective in some way, to see a broader range of perspectives. Oftentimes we look back on events and we think, I could have done something different. And those kinds of thoughts can be really heavy for someone to hold. They're very, very burdensome. And when people think they could have or they should have done something differently and they didn't, and it maybe would have had an impact on the outcome of an event that was incredibly traumatic. So when people have a chance to revisit some of these situations, for example, some people talked about revisiting traumatic events where they would actually talk to people who had died in those events, and they find out different perspectives about the event. They find out those people are doing okay and those people are wishing them well. They can actually have conversations with them and come to some sort of resolution. And in a sense, this is almost helping people to, really embody those different perspectives. It creates a sense of inner forgiveness and forgiveness all around. And I think a lot of people talked about forgiveness as a theme that arose from their journeys. Self-compassion and compassion for others were also themes that arose. And those help them to almost reprocess these traumatic memories. And almost you reconsolidate those as your memories of the event. And in a sense that those new reconsolidated memories become your experience of the event. So they're no longer holding this burden over you. You can reflect on those times and feel sad and feel, emotions we would normally experience, with it not necessarily affecting your day-to-day life in terms of being triggered.
Yeah, that's so interesting, because you were saying before that conventional psychotherapy for PTSD is very distressing and difficult and intolerable for these individuals. So it sounds like ibogaine allows that kind of reflection on your past and your traumatic experiences, but through a different kind of lens. Is that like a less distressing, more tolerable lens? Is that right?
Yes, and a lens that's much more filled with compassion and providing a broader range of perspectives.
Mm-hmm.
That
In terms of the mechanism, would you say that that's sort of the primary therapeutic mechanism? I know you also mentioned EEG and MRI, so did those sort of mechanisms also link into these more subjective ones?
Yes, the EEG findings Whether or not this is a primary mechanism, that's a great question. We don't know, and that's why more research needs to happen. We need to understand, are these, reprocessing events, are they primary mechanisms, and does this kind of prolonged event of being in a journey for so you're in a journey for 12 hours, and this really in-depth reprocessing helps you to heal from these events. Maybe it's like an accelerated, as Dr. Olash in his paper suggested, this could be looked at as an accelerated form of autotherapy, so self-therapy that's happening. Instead of 12 one-hour sessions over 12 weeks, you're doing this in one go. All this processing and reprocessing of information, and kind of removing those negative self-evaluations out of the way in favor of a much broader perspective and a broader understanding. There is a lot that happens in war, and we might reflect on things and think we had more control than we did at the time and more options. But in the time, maybe we did the best we could.
Yeah. And in terms of the EEG and MRI, did that correlated with these changes as well?
Yeah, so the EEG outcomes suggest that there are findings that are consistent with what we know about PTSD. There has been a second paper on EEG findings that's been submitted. It's now in preprint. It hasn't been peer-reviewed yet. And it's also finding that there is a similarity in what we're seeing in EEG from pre and post ibogaine treatment to what you would see in PTSD. So we're seeing some changes in EEG signals that are correlating with reductions in post-traumatic stress disorder symptoms, as well as increased day-to-day function. But we're also seeing EEG changes that kind of go along with what we know about PTSD and electrophysiology signals of the brain, that it's related to aberrant kind of frontal networks. And there seems to be this shift backwards. But again, that second EEG finding paper is in preprint right now.
So interesting.
And,
I'm excited to read it.
Yeah. And with respect to the fMRIs, we did see increases in regional cerebral blood flow in areas that corresponded with some changes in symptoms, particularly day-to-day function. We also saw some changes in cortical thickness, and we saw some really interesting reduction in estimated brain age. That paper is also, I think that paper has been accepted, and it's in pre-proof stage right now.
And the brain age piece is interesting. So do you think that is related to the alleviation of the mood symptoms and that being beneficial for the brain, or do you think that ibogaine is having a specific effect on like the aging aspect of the brain in general?
Yeah, so when I think about traumatic brain injury and I think about the impact of that on the brain, there's a greater susceptibility to neurodegenerative disorders later on down the road. So there's something that happens in the brain with traumatic brain injury that can lead to increased problems later on down the road. And I wonder if that has to do with maybe inflammation or something that's going wrong in the brain following injury. And maybe there's some kind of benefit that's happening related to the ibogaine that's maybe dealing with that injury and helping in terms of rolling back brain age a little bit. Brain age reduced by 1.3 years. There's like this algorithm that you can use to estimate somebody's brain age, and that was done before treatment, and then 1 month after treatment showed a reduction in brain age by 1.3 years. And we need to understand what that's about. We need to do more studies and get a better sense of what's going on there. We did see changes in cortical thickness, so increased cortical thickness. We need to understand, I think the theory is that it's related to increased neuronal densities and dendritic density, but we're not entirely certain. Ibogaine does increase the transcription of these protective factors called neurotrophic factors, that are substances that help to support brain function, that are substances that help to repair our central nervous systems. And so if that is happening, we can probably expect to see some benefit from this increased transcription of these neurotrophic factors. So wondering, is that what's happening here? And again, we need to do more research to try to look at all these different mechanisms that are occurring.
Yeah, it sounds like there's so many interesting future directions that are coming out of this study.
That's
So
right.
exciting. Are
Yeah.
you planning, are you working on, like, what is next for you in this sort of line of research? Are you guys planning a study building off of this in any way?
Yeah, so currently at the Stanford Brain Stimulation Lab, there is a study that is being planned to look at people with war-related trauma. It's being done in conjunction with the University of Zurich in Switzerland, and looking at people who have experienced war-related trauma. So trying to look at a bit of a different population, primarily women. And our study included only men. It wasn't by design, but that's kind of representative of Special Forces veterans. And we just didn't have any participants at that time who were women. So, so having primarily women will be a good, next step in terms of trying to understand the effect of hormonal differences, and different types of traumas that can arise.
Yeah, such an important area. And are you hopeful that these findings will sort of generalize to these similar populations or even civilians with PTSD? Are there any caveats here where you think it might not be the best option?
Well, again, this kind of takes me back to the safety question. There are certain safety risks associated with ibogaine, where we need to try to understand the safety in different populations. Are there different safety risks in different populations? Are there dosing questions that can be answered? Is there like a minimum dose to see changes that would maybe improve the safety of the treatment? Would it be as effective at a lower dose? Again, calling into question the role that mystical experiences in this reprocessing seems to play in terms of the strength of symptom reduction. So we don't know. We don't know the answer to these questions, but definitely we need to try to take a look at safety parameters. We also need to look at different indications. So as I said, there's these increased neurotrophic factors, and there's some literature out there on some changes in brain MRIs and symptoms for people with multiple sclerosis who've done ibogaine. Just a very limited, paper that reports 2 cases. So we need to try to understand where to do this research, and like you said, there's a lot of different questions arising out of what we know about ibogaine, and as we get to learn more, we'll maybe try to follow some of those directions.
Yeah. And would you say, in terms of the whole state of the field altogether, we're sort of now at the end of the conversation, so I kind of want to wrap it up in a way that people have sort of like a succinct understanding of the current state of evidence. So would you say it's primarily small studies? Do we have any randomized controlled trials? How confident are we that this is an effective intervention?
There have been a lot of studies on the use of ibogaine in treating opioid addictions and other addictions. So we have a pretty robust body of literature that probably will continue to grow. as we learn more and more and more about the mechanisms. So we do need to understand about ibogaine. Is it something that we need to consider as a first-line treatment? Given the safety risks, I don't know if that's the case. You know, this was considered almost a Hail Mary for a lot of the folk that went down to Mexico. They'd tried a lot of the different treatments and just hadn't been effective. But I think because of this kind of broad-ranging action that ibogaine has, it can affect a lot of different diagnoses at the same time. Mm-hmm. So we need to try to understand different populations, the different effects, different disorders, different effects, neurodegenerative disorders. Are there some impacts downstream that we're seeing from ibogaine for people who have sustained traumatic brain injuries? So there does need to be more research. There is research that's happening in Texas right now, and my understanding is they've had a study design where they had a waitlist control. So trying to look at what their outcomes will be, trying to look at different study designs to help provide a more robust science versus open label, where that can introduce a lot of biases. We need to understand, what about the co-therapies? For people doing ibogaine, I know at the clinic where our participants went, there was preparation that they did with therapists on an individual basis. Then afterwards, they did integration sessions with a therapist on an individual basis. And I think those are really important, along with psychedelic treatment, to help bring home meaning and to really optimize the safety of the treatment. There are also other things that our participants did, like when they did this psychedelic treatment, it seemed to open a door for them through which they could choose to walk if they wanted to, which allowed them to build new, healthier habits and change the way they interact with people. Really, it's an opportunity to make change. I don't know if you've seen the paper by Goldolan's group. I think the first author is Romain Nardou. He was a postdoc, I think, at the time, where they look at reopening of social reward critical periods.
Yes, actually, I have seen this.
Yeah. So their paper suggests that there may be ongoing effects in different substances that correlates to the amount of time you spend in the acute effect stage. So, things like ketamine is very short acting, a couple of hours, and the social reward critical periods reopen. These were animal models for maybe 2 to 3 days. For substances like psilocybin and MDMA, they reopen for about 2 weeks. So for LSD, it's about 4 weeks, and for ibogaine, it was kind of ongoing. They stopped, I think, measuring at 4 weeks, but they weren't seeing a drop-off in social reward learning. So it seems to open this window of potentially neuroplasticity. We need to understand this in people. Is that what's actually happening? But it seems to be that there are other things that can happen around psychedelic substances that maybe can bring increased openness and perspectives, being able to see greater perspective than what you saw before if you're continuing with psychotherapy. So we really do need to understand what is causing what. If someone were just to take ibogaine and there were no co-therapies, nothing, would it have the same effect? We're not really clear on that. So yeah, the set and setting is also very important. So understanding the role that plays with these therapies. Right now we understand that it is important, but we do need to learn more about the role that plays.
So many questions with
yeah.
area.
Yeah, so whether this would be a first-line treatment for PTSD, I'm not sure, given the safety profile right now that we know. I think it would be important to try other things first and see if those are helpful. And there might be even other some other psychedelic substances have been shown to have a better safety profile and to have some impacts on things like PTSD, depression. So those might be safer avenues to try. But definitely first-line treatments do have some efficacy. Mm-hmm. And those would be like medications and talk therapy.
Mm-hmm. Well, thank you so much, Dr. Cherian, for walking us through this and sharing your work. I'll definitely be following along. And yeah, thank you so much for your time today.
Thanks so much for having me.
Of course. Thank you so much for tuning into this conversation with Dr. Kirsten Cherian. I'd like to thank the Center for Psychedelics, Health and Research at Queen's University, the Ontario Brain Institute, the Canadian Biomarker Integration Network in Depression, and Providence Care Hospital. Until next time, be well and integrate wisely.